Amyotrophic lateral sclerosis, evidence-based use of Riluzole and Edaravone. Amyotrophic lateral sclerosis, ALS, affects is almost equal to 2.1 per 100,000 persons worldwide, causing progressive loss of upper and lower motor neurons and a median survival of is almost equal to 30 months from symptom onset. The disease is driven by a combination of glutamate excitotoxicity, oxidative stress, and TDP43 proteinopathy, which together precipitate motor neuron degeneration. Diagnosis relies on the revised Escorial criteria. Definite ALS requires clinical evidence of UMN and LMN signs in greater than or equal to 2 regions, with EMG confirmation, and the ALS Functional Rating Scale revised, ALSFRS R, to quantify disability. First-line disease-modifying therapy consists of Riluzole 50 mg PO/BID and Edaravone 60 mg for infusion, 5 days/2 weeks on, 2 weeks off, both of which modestly extend survival and slow functional decline. Key points. Note, Riluzole 50 mg orally twice daily, BID, improves median survival by 2.7 months, hazard ratio 0.84, P equals 0.02 in the pivotal 1996 trial. Edaravone 60 mg 4/30 minutes, administered 5 days per week for 2 weeks followed by 2 weeks off, reduces ALSFRS R decline by 33% over 24 weeks, P equals 0.001. Definitive ALS per revised Escorial criteria requires UMN and LMN signs in greater than or equal to 2 of 4 regions, bulbar, cervical, thoracic, lumbar, with EMG evidence of active denervation. ALS incidence is 2.1 cases per 100,000 person-years globally, with a peak age of onset at 62 years, range 45 to 78. Approximately 65% of ALS patients harbor a pathogenic variant. C9orf72 repeat expansion accounts for 38% of familial and 7% of sporadic cases. Baseline forced vital capacity, FVC, less than or equal to 80% predicts respiratory failure within 12 months in 48% of patients. Dysphagia occurs in 55% of patients by year 1 and in 84% by year 2. Percutaneous endoscopic gastrostomy, PEG, improves nutrition and reduces aspiration pneumonia risk by 31%. Riluzole requires hepatic monitoring. ALT 3 times ULN occurs in 7% of patients, prompting dose interruption. Edaravone is contraindicated in severe renal impairment, eGFR less than 30 ml/min/1.73 square meter, due to accumulation of the metabolite 2-hydroxyedaravone. The ALSFRS R score declines at a mean rate of 0.9 points/month without disease-modifying therapy. With Riluzole the rate slows to 0.7 points/month, P equals 0.04. King's clinical staging predicts 1-year mortality of is almost equal to 30% at stage 3, need for non-invasive ventilation, versus is almost equal to 5% at stage 1, symptom onset only. NICE Guideline NG42, 2022, recommends offering Riluzole to all patients with a confirmed ALS diagnosis and considering Edaravone only in patients with ALSFRS R greater than or equal to 35 and disease duration less than or equal to 2 years. Overview and epidemiology. Amyotrophic lateral sclerosis, ALS, is a progressive neurodegenerative disorder characterized by degeneration of upper motor neurons, UMNs, in the motor cortex and lower motor neurons, LMNs, in the brainstem and spinal cord. The International Classification of Diseases, 10th revision, ICD-10, code for ALS is G12.21, motor neuron disease, ALS. Global incidence is estimated at 2.1 cases per 100,000 person-years, with a prevalence of 5.2 per 100,000, translating to is almost equal to 400,000 living patients worldwide. 2022 WHO data. Regionally, incidence ranges from 1.5 in East Asia to 3.0 in Western Europe per 100,000 person-years, reflecting both genetic and environmental heterogeneity. Age distribution is markedly skewed. The median age at symptom onset is 62 years, interquartile range 55 to 68, with is almost equal to 90% of cases occurring after age 40. Male sex carries a modest excess risk, male-female ratio 1.3 to 1. Racial disparities are evident. In the United States, non-Hispanic whites have an incidence of 2.4 per 100,000, whereas African Americans have 1.5 per 100,000, adjusted relative risk 0.62. Economic analyses from the United Kingdom estimate an average annual cost of £46,000 per patient, driven primarily by hospitalizations, is almost equal to 45% of total cost, and assistive devices is almost equal to 30%. Pathophysiology. ALS pathogenesis is multifactorial, integrating excitotoxicity, oxidative stress, impaired protein homeostasis, and neuroinflammation. Glutamate excitotoxicity is mediated by excessive activation of AMPA and NMDA receptors, leading to intracellular calcium overload. Riluzole attenuates this cascade by inhibiting voltage-gated sodium channels, IC5 is almost equal to 15 m, and reducing presynaptic glutamate release by is almost equal to 30% in vitro. Oxidative stress is amplified by mitochondrial dysfunction. Edaravone scavenges free radicals via donation of a hydrogen atom, neutralizing hydroxyl radicals with a rate constant of 1.2 times 10 m superscript 1 s superscript 1. Genetically, pathogenic variance in SOD1 is almost equal to 20% of familial ALS, impairs superoxide dismutation, raising intracellular superoxide levels by is almost equal to 2.5-fold. TDP43 proteinopathy, present in is almost equal to 97% of sporadic ALS, leads to cytoplasmic aggregation and loss of nuclear function, correlating with disease progression. Higher phosphorylated TDP43 burden predicts a 1-year faster ALSFRS R decline, beta equals 0.12, p equals 0.01. Animal models, SOD1G93A transgenic mice, display motor neuron loss beginning at postnatal day 90, with peak decline at day 120, mirroring the human disease trajectory of 3-5 years from onset to death. Clinical presentation. The classic ALS phenotype presents with a combination of UMN and LMN signs. In a prospective cohort of 1-200 patients, 71% reported limb onset, predominantly distal weakness, 24% had bulbar onset, dysarthria, dysphagia, and 5% presented with respiratory onset, dyspnea, orthopnea. Limb onset disease manifests as progressive weakness in the hand, 70% of limb onset cases, and foot, 55%. Fasciculations are detected in 86% of patients, while spasticity, UMN sign, is present in 68% at diagnosis. Atypical presentations occur in 12% of patients over age 70, often with predominant gait disturbance and minimal fasciculations, leading to misdiagnosis as peripheral neuropathy. Diabetic patients may exhibit overlapping neuropathic symptoms. In a case control series, 18% of ALS patients had coexisting type 2 diabetes, and their disease progression was faster. ALSFRS R decline 1.1 points/month versus 0.8 points/month, p equals 0.03. Immunocompromised individuals, e.g., post-transplant, may present with rapid bulbar decline. 9% of such cases develop respiratory failure within 6 months. Diagnosis. 1. Clinical suspicion based on progressive focal weakness with combined UMN/LMN signs. 2. Baseline investigations, CBC, CMP, including ALT, AST, ALP, bilirubin, CK, reference less than or equal to 200 U/L, serum electrolytes, fasting glucose. 3. Neurophysiology, EMG/NCS demonstrating active denervation, fibrillation potentials, positive sharp waves, in greater than or equal to 2 regions. Sensitivity is almost equal to 95% for ALS when combined with clinical criteria. 4. Imaging, MRI of brain and spinal cord, 1.5 T or higher. To exclude structural lesions, MRI sensitivity is almost equal to 70% for detecting ALS-related corticospinal tract hyperintensity, but specificity is almost equal to 90% when combined with EMG. 5. Apply revised Escorial criteria. 6. Genetic testing. Panel covering C9orf72, SOD1, FUS, TARDP, recommended for all patients with a family history or onset less than 45 years. 7. Biomarker assessment. Serum NFL, greater than or equal to 30 pg/ml suggests aggressive disease, and CSF PNFH, greater than 0.5 nanograms per milliliter, for prognostication. Key points: definite ALS, UMN and LMN signs in greater than or equal to 2 regions, EMG evidence of LMN degeneration in greater than or equal to 2 regions. Probable ALS, UMN signs in greater than or equal to 2 regions, LMN signs in greater than or equal to 1 region, EMG in greater than or equal to 2 regions. Serum CK, median 180 U/L, range 50 to 300 U/L. In ALS, elevations 2 times ULN occur in 12% and do not alter management. Liver function tests, baseline ALT/AST, monitor every 4 weeks for the first 3 months on Riluzole, then quarterly. Management and treatment. Patients presenting with acute respiratory decompensation require immediate stabilization, supplemental oxygen to maintain SpO2 greater than or equal to 94%, non-invasive ventilation, NIV, if FVC less than 50% predicted or PaCO2 greater than 45 mm of mercury, and arterial blood gas monitoring every 4 hours. Airway protection is indicated when bulbar weakness leads to choking episodes, 3 episodes/day. Intravenous fluids should be limited to less than or equal to 1 L/day to avoid pulmonary edema in the setting of impaired cough. Drug generic dose, route, frequency, duration, mechanism, expected response, Riluzole 50 mg oral bid indefinite, continuous, inhibits voltage-gated NA channels, reduces glutamate release. Median survival extension 2.7 months, HR 0.84, Edaravone 60 mg, intravenous, 5 days per week for 2 weeks, then 2 weeks off, 30-min infusion, 24 weeks, minimum. Free radical scavenger, attenuates oxidative stress. References. 1. Talaco et al. Amyotrophic Lateral Sclerosis, Pathophysiological Mechanisms and Treatment Strategies, Part 2. International Journal of Molecular Sciences. 2025, 26, 11. PMID, 40508048, https://pubmed.ncbi.nlm nih.gov/40508048. DOI 10.3390/IJMS 26115240. 2. Sepleff et al. Current state and future directions in the therapy of ALS. Cells. 2023, 12, 11. PMID 37296644, https://pubmed.ncbi.nlm.nih.gov/37296644. DOI 10.3390/cells12111523. 3. Everett W. H. et al. Tofersen for SOD1 ALS. Neurodegenerative Disease Management. 2024, 14, 5149-160. PMID 39330700, https://pubmed.ncbi.nlm.nih.gov/39330700. DOI 10.1080/175822024.2024.2402216. 4. Gupta et al. Advances in Understanding and Treating Amyotrophic Lateral Sclerosis, ALS, a Comprehensive Review. Curious. 2023, 15, 11E48691. PMID 38090405, https://pubmed.ncbi.nlm.nih.gov/380904005. DOI 10.7759/curious.48691. 5. Witzel et al. Safety and effectiveness of long-term intravenous administration of Edaravone for treatment of patients with amyotrophic lateral sclerosis. JAMA Neurology. 2022, 79, 2121-130. PMID 35006266. https://pubmed.ncbi.nlm.nih.gov/350062666. DOI 10.1001/JAMA-Neural.2021.4893. 6. Anonymous. Riluzole for ALS. The Medical Letter on Drugs and Therapeutics. 2022, 64, 1664-190-191. PMID 36397190. https://pubmed.ncbi.nlm.nih.gov/363979190. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.